So my talk will be mostly on what Professor Savarese talked before, but more in advanced chronic kidney disease and diabetes. And I will also talk about what we are doing in Italy about collecting data on our failure population. Those are my disclosures. So in recent years, we had an improvement of the available treatment for our failure patient. And if you think about this is from 2023, just in 1 year, we also have information on non-steroidal MRA and GLP-1 receptor agonist. But we also know that the implementation of medical therapy improve the outcome of our patient more than the single therapy alone. And this is our data from the pooled analysis from Paradigm and Paragon, Rails, Emphasis, and TopCat, and Emperor, Reduced, and Preserved. So the idea is to combine more medical therapy for having a better efficacy in terms of cardiovascular outcomes. But as I previously said, my talk is more about chronic kidney disease and diabetes, and we know that these conditions are mostly interrelated each other and increase the risk of worse cardiovascular outcome in our population. So I will try to talk about what we know about the foundational therapy in our failure in patients with chronic kidney disease. I will start with the MRA. In this pooled analysis of Rails, Emphasis, TopCat Americas, and the Ephesus trial, we can observe that the efficacy of spironolactone and MRA is consistent across the baseline eGFR. So also among patients with low eGFR at baseline, there is a slight interaction for those with very low eGFR, but the authors also assess whether patient after taking MRA on therapy had a reduction of eGFR below 30%. This was an analysis from the Emphasis and Rails. Around 7% as a reduction of eGFR. This patient experienced higher risk of cardiovascular outcome, but the effect of MRA were consistent regardless of the drop of eGFR after the initiation of MRA as a medical therapy. And moving to sacubitril/valsartan, we saw the similar trends of efficacy across the baseline eGFR in terms of kidney outcomes. So in terms of reduction of eGFR, development of a stage renal disease, and kidney replacement. And the results were consistent both in Paradigm and in Paragon. Interestingly, as we all know, there is commonly a drop of eGFR when we start sacubitril/valsartan, and this is both for a reduced and preserved ejection fraction. So when we ask whether this drop, the initial drop in the running phase, has an impact on future cardiovascular outcome, the authors of both Paradigm and Paragon replied to this question with this elegant study showing that regardless of the initial drop of eGFR, we have a consistent efficacy of sacubitril/valsartan across the ejection fraction spectrum. And we also tested whether the addition of MRA in patients taking sacubitril/valsartan improve the protection of kidney outcomes, and we showed this data last year at the ESC HFA from the Paraglide and Paragon data. So patients taking with HFrEF and HFpEF on sacubitril/valsartan and background medical therapy with MRA had a greater reduction in kidney outcomes. So moving to SGLT2, as Professor Savarese said, this is the first pillar that showed a consistent efficacy across the ejection fraction spectrum. But as we all know, SGLT2 were initially tested in diabetic population. So we know that SGLT2 are consistent in patients with heart failure across the EF spectrum, regardless of the history of diabetes, but also regardless of baseline eGFR. So in this pooled analysis of the liver, Emperor Preserved, HFpEF, and the Emperor Reduced trials, the efficacy of SGLT2 were similar with around 22% risk reduction of hospitalization for heart failure or CV death, regardless of baseline eGFR. And as I previously said for MRA, the question of whether the initial drop in the eGFR after the initiation of SGLT2 should alert the clinician about continuing medical therapy. So in this pooled analysis of DAPA and the liver, around 3% had a drop of eGFR after the initiation of dapagliflozin, but this patient, of course, experienced a higher risk of event, but the efficacy of dapagliflozin was consistent regardless of the drop of eGFR after the beginning of SGLT2 as a medical therapy. But if we do a step back and we see the HFpEF across the cardiokidney metabolic spectrum, we can also see that overall SGLT2, regardless of the baseline diabetes status, improve kidney outcomes in our population. This is not, again, HFpEF, but more broadly, considering patients across the cardiokidney metabolic spectrum. So we know that now we can confidently use SGLT2 in patients with heart failure, in patients with chronic kidney disease, and in patients with diabetes. And of course, one of the last updates regarding finerenone, it also showed consistent result in patients with HFpEF, and the efficacy was consistent in patients with diabetes, and regardless of baseline eGFR. The authors also recently showed that finerenone in this population reduced the risk of new onset of microalbuminuria and favorable effect on in the UCR over time. And of course, in the pooled analysis of Fidelio, Figure, and Fenarts, there is a consistent effect by reducing the composite kidney outcome. This is, again, a wider spectrum across the CKM syndrome. And finally, of course, we have the GLP-1 receptor agonist. These drugs showed efficacy in patients with HFpEF, but if we look at the CKD outcomes, this is the first trial designed primarily for assessing CKD outcome in this population in patients with diabetes and risk of CKD. 20% risk reduction over time for the composite kidney outcome of reduction of 50% of eGFR, death due to kidney disease or end-stage renal disease, with a difference in annual slope of 1.16 milliliter per meter per year. And again, if we consider the use of GLP-1 broadly in patients with diabetes or in patients without diabetes with the recent data about the SELECT trial, we can see overall a 20% reduction of the kidney outcome regardless of the diabetes status in patients with diabetes or not with chronic cardiovascular kidney disease. And the combination of this therapy that I showed you in this presentation, SGLT2, GLP-1, and non-steroidal MRA, overall reduce the risk of developing kidney disease in population with type 2 diabetes and albuminuria. So moving to the HFpEF, again, this should be probably the new approach to treat our patient. So a first-line upfront approach with SGLT2 and non-steroidal MRA, and there are other therapies like diuretic agent, sacubitril/valsartan, and incretin-based therapy that should be provided based on the phenotype of our population. So this is what we are doing in Italy. We designed a couple of years ago this registry called the HFrEF. This is an ongoing study that is collecting data regarding the implementation of medical therapy in patients with heart failure across the ejection fraction spectrum. So we are including both patients with HFrEF and patients with HFpEF. And of course, we'll also collect data regarding the phenotype of this population, the clinical outcomes. Again, this is still an ongoing study. These are just some preliminary data regarding the background medical therapy at baseline across the ejection fraction spectrum. As you can see, less than 50% of the population was in quadruple medical therapy, in patients with HFrEF, 27% in triple medical therapy. The trend was very similar in patients with mildly reduced and preserved, and of course in patients with HFpEF, only 16% of the population was in quadruple medical therapy. But I want to conclude my presentation showing you what we are planning for the next future, to design a new registry to collect data, moving in a wider perspective, not only for heart failure population, but across the cardio-kidney metabolic spectrum. And of course, we want to move not only in our country, but to collect data across worldwide, and these are the countries, of course, that we are trying to involve in these registries. Not started yet, but hopefully we will start in 2025. And again, this will provide not only data for our failure, but across the new medical therapy, across the CKM syndrome. So in conclusion, foundational therapy for heart failure with reduced ejection fraction showed consistent benefit in patients with CKD and or diabetes. In patients with HFrEF and HFpEF benefit from the use of SGLT2 and non-steroidal MRA across the CKM spectrum. And finally, in patients with CKM, the use of SGLT2, GLP-1 receptor agonist, and non-steroidal MRA appear to slow the kidney disease progression and eventually reduce the risk of cardiovascular outcomes. Thank you for your attention.